My name is Giuseppe Rosano. I'm a cardiologist from Rome and London, and it's a pleasure to have today with me Jeffrey Borer, Professor of Medicine and Cardiology at State University of New York. We will be talking on relevant problems on polypharmacy and how polypharmacy often can be a problem in patients with cardiovascular disease. We will focus mainly on three areas: in patients with severe renal disease, in patients with preserved ejection fraction, and in patients with syncope. So the first question, Jeffrey, is how shall we manage patients with renal disease and cardiovascular disease in terms of polypharmacy?
Yeah, that's a very important question, a very difficult one, and it's most difficult in the area of heart failure with reduced ejection fraction and systolic heart failure, because here we have a large evidence base that supports the use of polypharmacy, that supports the use of 5 different drugs in every patient. Well, that's a problem. If a patient has renal disease, those drugs may not be optimally handled. The doses may need to be changed. That's a problem because we don't have studies to tell us how to change them. The data we use to alter doses in patients with heart failure is based on extrapolations of small studies done in patients with other diseases for other purposes. The primary purpose of reducing doses is to prevent major secondary adverse events, whereas the reason we give the drugs to patients with heart failure is to make them live longer and stay out of the hospital. We have no idea what the dose alteration does in terms of keeping them alive and keeping them out of the hospital. So that's a big problem. One of the areas that came up in discussion this morning that was particularly interesting was the use of anticoagulants. In patients with heart failure, atrial fibrillation is common. We anticoagulate patients with atrial fibrillation to prevent strokes. But it was pointed out by one of the speakers this morning that even warfarin, the most common and oldest of the anticoagulants, is beset with certain problems in patients with kidney disease. They may have more bleeding than expected in the absence of kidney disease. They may even have more clotting than in the absence of kidney disease. So what do? Well, this is something we didn't discuss in very great detail, but I think is very important. We have large databases that tell us what is best for the great majority of patients. But those data have to be interpreted for every individual patient. And the patient I presented this morning, who was 82 years old with atrial fibrillation and reduced ejection fraction, that is systolic heart failure, well, you have to take into account the kind of work that he does. He's a movie producer. If he bled and didn't die from the bleeding, well, okay, that's a problem. But if he had a stroke, his work would be over, his life would be over. His intellectual function could be damaged to the extent that he couldn't do his work, would be very unhappy. So these data have to be interpreted for the individual patient. We talked about that with regard to HFpEF as well, heart failure with preserved ejection fraction. There are no data about any drugs that can improve survival or keep people out of the hospital. We have no data, so there are no guidelines to tell us how to move along. And a question came up, would you use the drug ivabradine in that situation to slow the heart rate?
Yeah, that is an important issue because it's when we discussed about heart failure with preserved ejection fraction, basically what came out is that we don't have any drug that has shown any efficacy in HFpEF, but we still have patients with high heart rate, and where high heart rate is significant. Maybe patients with COPD, they use beta stimulants that may increase heart rate.
Yes.
So how would you manage and how would you use drugs with like ivabradine, given that you cannot use massive doses of beta blockers?
That is a major problem, and the answer is, I don't know, because there are no data. Ivabradine, I've been involved with the study of ivabradine in heart failure with reduced ejection fraction for many, many years. Very useful in patients in sinus rhythm. But preserved ejection fraction, we have no data. Theoretically, it seems reasonable to expect that if you slow the heart rate, you'll increase the time available for the heart to fill, and the lack of adequate filling is the major reason why people develop heart failure with diastolic dysfunction. But does it really work? Are there adverse effects that would counteract the potential benefits? We just don't know. Personally, if there weren't potential problems with regulatory authorities, I would use ivabradine, but I don't think we have the data to tell us. So you have to do the best you can.
Yes. And this is a major problem in patients with comorbidities. I mean, it's because often you get patients with thyroid disease that then need to get thyroid replacement, and I said about beta stimulants. The last point also that we touched upon was on syncope in patients with polypharmacy and optimal blood pressure levels in patients who get orthostatic hypotension. So what is your advice on that?
Yeah, it's a very important discussion. We don't know what the optimal blood pressure level is in such patients, but it's higher than it is for people who don't have syncope, intermittent syncope. I think that the most important point that came out of that discussion was you need to do a complete evaluation of the cause of the transient loss of consciousness, because one size doesn't fit all. There are many potential causes. Unless you make a thorough search for the cause, you're not going to be able to figure out the proper therapy.
So thank you very much. It's basically the main message that came across from the session is that polypharmacy is a problem. Yet we still have to implement effective therapies. Sometimes, especially in the elderly, we have to be a little bit cautious and go slowly, but we have to go. Of course, we have to be aware of the possible indication and contraindications and limitations in patients with renal insufficiency especially, and but treat our patients and try to treat at the best. Thank you. Thank you, Jeff.
Thank you.